All right, good morning, everyone. Welcome to our meeting. It looks like we've got quite a few people online that have joined us already. Perhaps a few more will be joining in the next few minutes. I'm sure that you, for those of us that are new out there, welcome to your first meeting. We're glad that you're able to join us. For those of you that have been here in the past, I'm sure that you will recognize one of George's favorite slides here, welcoming to our meeting. Look who's smiling. Just a nice little pick-me-up at the beginning of the morning. And always remember, prostate cancer, it's only 2 words. It's not a sentence. So I hope that everybody's dealing with the coronavirus sufficiently. It is still likely that we will not be able to meet in the auditorium for the rest of the year. But until then, we'll be continuing to have John Tassi set up this live streaming instead of our regular in-person meetings. And these streams will continue to be on the 3rd Saturday of each month. Myself, I'm Aaron Lamb, and please bear with me as this is my first time acting as meeting facilitator. Your hosts today include a number of the volunteers with the organization. First off is Lyle LaRoche, who's our president and director. Hang on just a second. Lyle has a great video message on our website that I recommend everyone watch if you have not already. Gene is another director and longtime member of the group, and he's been facilitating a lot of the online streaming meetings since we've all gone into quarantine. Bill Manning is our director and videographer. He's done a fantastic job of recording all of our in-person meetings in the past. And John Tassi, who is also director and our webmaster, and he's running all of the video streaming while we're online. Myself, Aaron Lamb, I'm the new facilitator of the meetings. We also have Steve Pendergast, who does an excellent job putting together a monthly newsletter that hopefully you've all received. Old copies of the newsletters are all available on the website. They're an excellent source of information. I highly recommend that you browse all of the old newsletters if you haven't already. There's just a wealth of information there. And included in those newsletters are meeting summaries that our volunteer Bill Lewis writes up. And these are almost verbatim of what went on at the prior meetings. They really are fantastic to refer to in the future. We have about 900 members. Many have been part of this for 10 to 20 years. Myself, I've only been a member of the organization for about 3 years now, I guess. But everyone is a volunteer, and you can be too. We provide a variety of support. Our website, www.ipcsg.org, is a great site that John put together. A lot of information on there, as I've already mentioned. The key thing to remember is you really have to memorize the name of the organization, because myself, I can't even remember the order of the letters, but Informed Prostate Cancer Support Group. On there, you can find the newsletters, as I've already mentioned, and the monthly video streaming link, such as you clicked on today or got via email. We're always on the 3rd Saturday of each month. And another thing I want to mention is this is the hotline number. For those of you that are new, this organization is not just intended to be a streaming site in vacuum. When we're in person, we are networking, we're talking to each other, we're helping each other out. And some of you out there might have only been recently diagnosed with prostate cancer and have a lot of questions. And I recommend to give this number a call as soon as you have a chance. I believe it's Jean that will answer the call, and we'll put you in contact with a number of people that can be very helpful in helping you to make an informed decision about your care. There is also an email contact on the website itself too that you can use. So our support group purpose, we share patient-focused experience on becoming your own case manager through informing, networking, and caring. We are a group of experienced participants. Pretty much all of us have or have had prostate cancer and are actively battling it or wondering what to do next. We are not medical professionals though, and any sharing by anyone of our group may not be a substitute for your medical counsel. We're here to help you make an informed decision for your own personal situation. We do need your support. We are a 501c3 nonprofit organization, and that means that your donations are tax deductible. We have no medical or religious affiliations. During the coronavirus, we are video streaming our meetings, but our costs remain very much the same. The majority of our costs are from advertising in local newspapers in order to get the word out about our organization to recently diagnosed men. We also have the cost of maintaining the website, and I apologize, I forget, there's another cost I wanted to mention, but I don't recall it at the moment. So please do make a donation. You can do that online via PayPal on our website, or you can send a check to the following address. And this address is also available on the website. We really do appreciate your support, especially during these times when we're not meeting in person. Our next meeting next month, we'll have Dr. John Eink. He's a radiation oncologist here at UCSD, professor of radiation medicine and applied sciences. And we'll also have Carl Rossi, also a radiation oncologist, and he's the director of the California Proton Treatment Center here in San Diego. But as far as today's meeting goes, we have Dr. Sumit Subudhi of the MD Anderson Cancer Center. Dr. Subudhi is a medical oncologist and immunologist whose research focuses on the mechanisms and pathways within the immune system that are responsible for tumor rejection. Dr. Subudhi's work includes examining the effects of targeting immune checkpoints in prostate cancer and continuing to uncover the mechanisms that tumors use to evade the immune system. And so with that, I'll turn it over to Dr. Subudhi. Please take it away. Thank you.
Thank you, Aaron, for that kind introduction. These webinar talks are a little bit more challenging than seeing the audience live. And the reason for that is it's hard to read the audience in this setting. I like my talks to be much more interactive. So when I put up my screen of slides, please feel free to interrupt at any point. I know we're a little bit pressed for time, but I can always skip some slides and get to the points that the audience feels is a priority. So I'm going to share my screen now. I can find a way to do that. You know what? I'm not seeing that that ability to share like we did earlier. Can I get some technical assistance?
Yeah, hopefully you can hear me right now, Doctor.
I can.
Oh, yay.
Oh, share screen. I see it now.
Okay, great.
Let's see this. And now let me put it in this mode. And then I have display settings. How's that? Let me get my pointer up. Okay, I think we're ready to go. So today I'm going to talk about the developments of immunotherapy for prostate cancer. But I want to start off with some basics because as I understand, there's some people that may be new to prostate cancer, meaning that they have a loved one or they personally have been recently diagnosed. So I want to just introduce what the prostate is. It's an organ that's found only in men. It helps to liquefy our ejaculate fluid or semen. And it's known for actually causing problems, not for doing good things like infections, causing urinary symptoms, or as we're here for, cancer. So where's the prostate located? It's located right below our rectum. That's why many of us who are in the field or patients with prostate cancer get digital rectal exams quite often. And it's because it's when we put our finger in, this right here is the prostate that we're feeling for. So I'm trying to advance my slide and let's see next, here we go. So when we think about how many patients a year get diagnosed with prostate cancer, it's pretty high in the US. It's about 240,000 new cases per year. It is the leading cause of cancer in men. The next one is lung cancer. And that's at around 120,000, so half as much. But when we think about what's the causes of death for men, it turns out lung cancer is number one, around 90,000, whereas prostate cancer is at 30,000. This is a really important thing to understand because what this tells us that not everyone that gets prostate cancer is going to die from it. Whereas with lung cancer, the majority of people who get it will actually pass away from it. And it actually affects the treatment choices that we recommend for our patients. Here are some risk factors for prostate cancer. When I say unmodifiable, these are things that you just have no control over, such as age, race, family history / genetic factors. But this is the one risk factor that many of us do have control over, and that's diet. And patients with what we call a beer belly or just a lot of fat around the belly, this is known to be a major risk factor. And so in my clinic, diet and exercise is something we focus a lot on. So when we think about risk factors, again, there's age, race, and family history. I don't want to spend too much time on this, so I want to get to the meat of the talk. But I just want to point out, I don't think of age as just a number, because this man here is 50, and you can see these men here in their 80s are actually racing. And so I treat the person in front of me. So I don't want anyone to just say, well, I'm 76 and I shouldn't get surgery. That's not how I think at all. So how do you prevent prostate cancer? Healthy eating, exercising regularly, and maintaining an ideal weight is the key. But there's no magic medication or pill, because I know many of us are always looking for that. So I'm not a big fan of recommending herbal medications or vitamins. I just think that healthy eating and exercise are the key. What are symptoms of prostate cancer? These are just some of the list. Understanding the prostate's located right above the rectum and below the bladder, you can imagine that urination symptoms are quite common in prostate cancer, as well as ejaculate or difficulty having erections. And then for some patients where the prostate cancer has spread to the bones, they can actually start experiencing pain in certain areas. So these are the tests for prostate cancer: a digital rectal exam and a blood test known as PSA, or prostate-specific antigen. There is no normal level, even though this magic number 4 nanograms per milliliter is traditionally thought to be a cutoff. I can tell you my father was just diagnosed this month with prostate cancer, and his PSA was less than 4. So I don't want anyone to walk away here thinking there is some magic number, and we can talk about that later. So usually when PSAs are between 4 and 10, that's when people can consider biopsy as one option. But let's talk about take a step back and figure out what is PSA. It's a protein that's actually made by the cancer cells itself, but also from normal prostate. It was FDA approved from the Food and Drug Administration just to monitor prostate cancer progression in 1986. But then in 1994, the Food and Drug Administration said that it can be used in combination with the digital rectal exam to screen for prostate cancer. What affects blood PSA? So these things, all the factors on the left, cause the PSA to go up. So just having an enlarged prostate, age, infection, ejaculation, bicycling, horseback riding, and cancer. Now, a lot of my patients refuse to ride their bikes because they're afraid that their PSAs will go up. I just want people to understand, they should at least leave here understanding that riding a bike is a good thing, and just because your PSA goes up does not mean bad things are happening, okay? So I encourage my patients to ride their bike as often as they can. And then things that can lower PSA levels, medications, herbal products do as well. And so many of my patients take herbal products to lower their PSA, and I try to make it very clear to them that they're just tricking us, and we may not be diagnosing it or understanding how our treatments are working if they're taking herbal products without us knowing. And then also weight can affect the PSA. So when patients get diagnosed with prostate cancer, they are given a Gleason score. And so I want to make sure that we all walk away from here understanding what a Gleason score is. This score was developed by Dr. Donald Gleason, who's a pathologist, a type of doctor that looks at cancer under a microscope. And when he looked under a microscope, he saw 5 different types of prostate cancer. And because his last name is Gleason, he gets to call it Gleason 1, 2, 3, 4, and 5. And so the key to remember, and the way to describe it to my patients is, 1 means that the prostate cancer looks closest to normal prostate tissue. Whereas 5, it looks least like normal. Therefore, Gleason 1 is considered a less aggressive prostate cancer, and a Gleason 5 is considered the most aggressive. But Dr. Donald Gleason also felt like that each patient should get 2 scores. So the lowest score you can get is a 1 + 1, which is 2, and the highest score you can get is a 5 + 5, that's 10. So what's the difference between the first score and the second score? Well, the first score tells you what's most predominant when they look under a microscope. And the second score is what's second most predominant. And together you get the score. Why is the score important to someone like me? It's important because we know that Gleason 2 to 6 are considered low risk prostate cancer, and Gleason 8 to 10 are considered high risk. Then the question is, what are we talking about risk? What kind of risk? Well, it's a risk of the cancer spreading or metastasizing, so leaving the prostate and going to another place, such as the bones or the lymph nodes, which are the 2 most common places prostate cancer likes to travel in a body. And the other risk is actually dying from prostate cancer. And remember, I want to take you back to one of my first slides where I said a majority of people don't pass away from prostate cancer, and that's because a majority of people have Gleason 6 prostate cancer. So I want to take you through this slide here. So what we're looking for or looking at on the y-axis are different milestones in someone's prostate cancer. So the first milestone is the cancer develops, but no one knows about it. The second milestone is a PSA milestone, which usually is used as a trigger to diagnose the cancer. The next milestone is that the prostate cancer spreads beyond the prostate. and goes into the local lymph nodes or goes into distant places like further away lymph nodes or bone. And then the final and the most unfortunate milestone is death itself. And then on the x-axis, and it's missing here, is time. And it doesn't matter. Time is usually measured in years here. And so I want to show you 4 different patient examples. So here's patient A, where the cancer develops right around here. And you can see that even though the patient A has cancer, they will never even be diagnosed with it because the PSA was never high or they weren't having any symptoms. And they're going to live with their prostate cancer. They're going to be one of the majority that's okay with living with their prostate cancer. Then there's patient B, who gets diagnosed because the PSA is greater than 4, gets a biopsy done, gets diagnosed with prostate cancer. And then the question is, do we treat it? Do we do surgery? Do we do radiation? Do we give hormonal therapies? And the truth is, in our clinic, we would recommend the patient do something called active surveillance and just watch it, because you can see, if you look at patient B's life trajectory, this patient's prostate cancer will never leave the prostate. So this is someone that patients A and B don't need active treatment for their prostate cancer. Now let's look at patient C. Patient C has a more aggressive prostate cancer that was diagnosed, again, because of PSA, where you can see the prostate cancer is aggressive and will spread with time. So this is a patient that we should really be thinking about doing surgery and radiation right up front. And then there's patient D with the most aggressive, where usually they're diagnosed with advanced prostate cancer and they're most likely not curable. And these are the patients I see 95% of the time in my own clinic. And this is where we're trying to figure out how immunotherapies can work. Okay, then I heard that next week, I believe you guys are going to be getting 2 talks from radiation oncologists. I just want to really make people understand the doctors that are involved with prostate cancer. Usually the first line doctor is a primary care doctor or generalist that's doing the PSA testing. The other type of doctor is a urologist. And these are known to be, they're trained as surgeons, but they're just focused in on the prostate. And then the third doctor is a radiation doctor that can actually radiate the prostate to potentially cure it. And the fourth type of doctor is me. I'm a medical oncologist. So I deal with cancer that's all over the body, and I'm trying to figure out drugs to use to help keep the cancer under control. And then the 2 other doctors that will be involved in your care, but you won't ever see them because they're in the background. So there's a pathologist that looks at tissue under a microscope, and that's like Dr. Donald Gleason, who developed the Gleason score. And then the radiologist who looks at your scans, the CAT scan, the bone scans, the MRIs. So this is what they do. Okay, now to the heart of my talk, which is immunotherapy. So why immunotherapy? Is because we know the immune system can actually kill cancer cells. How do we know this? So what we're looking at here in the middle is a big cancer cell surrounded by 4 T cells in purple. And with time, these T cells actually have successfully killed the cancer cells. What's great about the immune system is that it's adaptable, it's specific, and it has memory. And the memory is the key part because it can actually lead to cures in a subset of patients. And it's just the same way with our immune system. Once we get an infection, we usually never get that infection again because our immune system remembers it. And the next time that infection tries to attack our body, it's ready for it. A lot of people think immunotherapy is something new. It's not. This is from 1892. This is the grandfather of immunotherapy, William Coley, who was at Memorial Sloan Kettering Cancer Center, which I think at the time was called New York Hospital. He cured his first patient by taking bacteria products and literally injecting it into the cancer right here that you're seeing. This particular cancer was sarcoma of the neck, and by injecting the bacterial stimulant, and it was a form of immunotherapy that actually cured it. So what's in these bacterial products that allowed for this cure? And so William Coley called it Coley's toxin, and it consisted of a specific type of bacteria known as Streptococcus pyogenes. And he cured his first patient in 1891, and the magic substance in it was a cytokine known as TNF alpha, or tumor necrosis factor alpha. And this is just his niece published a paper in 1992 of his life's work that was all in a diary. And you can see that he treated 104 patients with sarcomas, and 22 of those, so approximately 20%, were alive 20 years later, meaning they were cured from it. So it's pretty remarkable. Over 100 years ago, immunotherapy was working. So let me take one step back. So the question is, well, why didn't this continue? Well, it turns out Madame Curie came from France, and she had discovered radiation. And radiation actually cured more people than immunotherapy. So Memorial Sloan Kettering decided to focus on radiation therapy, and then immunotherapy took a back seat. I also want to point out that bone marrow transplantation, which is not used for prostate cancer, but is used in other cancers, has been around since the 1950s, and now it's a standard of care in many types of cancers, especially blood-borne cancers such as leukemias and lymphomas. So many of us know that the immune system is there to fight infection, but what we forget is the immune system is actually there to also fight cancer. And so it can actually identify the cancer cells, and it actually can kill them. So the ones that we see in clinic, so all the cancers that we have diagnosed ourselves, are because the cancer has learned to somehow evade the immune system. And how do we know that that's true? Because when you think of patients who are immunosuppressed, so what do I mean by the word immunosuppressed? It means that the patients don't have a normal immune system. And these are patients that either have HIV, or they've had transplants, like a heart transplant or a lung transplant, kidney transplant. And as a result of the transplant, they're on drugs that suppress their immune system so that the transplanted organ can remain in the body. And when you look at the number of cases of, for example, skin cancer, you can see there's a lot more in the immunosuppressed patients versus what would be expected in a normal population. And in fact, in prostate cancer, it's twice as much as what you would see in a normal prostate, in a normal population. All right. So this is a complicated slide, so I'm going to try to simplify it. Here's a cancer cell in the middle, right here. We call it the tumor cell. And surrounding it are a bunch of different immune cells. And one of the main parts of the slide that I want to bring, or main points I want to bring out, is that not all immune cells are good. There are some immune cells that help kill the cancer, and there's some immune cells that actually help the cancer grow. So all these on the right, these are all immune cells that actually help the cancer grow, such as an immature dendritic cell, a myeloid-derived suppressor cell, a regulatory T cell. And then all these on the left actually help kill the cancer, such as a mature dendritic cell, CD8 T cells, Th1 T cells. So when we think about immunotherapies, what we're trying to do is we want to shift the balance within the body. We want to boost more of these good cells and get rid of these bad immune cells, okay? So that's the main purpose of immunotherapies. So how can we do that? There's many ways of doing immunotherapy. One is a bacterial stimulant, which I showed you earlier. The other way is using cytokines, and I'll give you examples of that. Another way is cancer vaccines. And then finally, the focus of the talk today will be mostly targeting immune checkpoints, which is the hottest thing in prostate cancer, or not prostate cancer, but just in cancer treatments right now. So many of us may remember back to 1985, back when Fortune magazine was considered an elite magazine, found it on a lot of people's coffee tables. Well, at that time, the cancer breakthrough was thought to be the cytokine interleukin-2. And it turns out this didn't end up being as much of a breakthrough as we thought. Now I want to point out the vaccine. Sipuleucel T is the generic name. Many of us know it as Provenge. And this is a vaccine where a patient gets connected to this machine here. And what happens, the machine filters the patient's blood and keeps some of the immune cells and returns the rest of the blood back into the patient. The patient's immune cells are then mailed to a company where the company teaches the immune cells, and in particular, the dendritic cells, how to fight the cancer. And then the product is put back into the patient 3 days later. And that's this vaccine called Provenge. And when they compared Provenge to placebo, and what we're looking here on the y-axis survival, so in the beginning of the clinical trial, all the patients were alive. And then as you go towards 0, you can see patients are passing away. And then what you have here is time in months. And what you can see is when we look at 50% of the patients, there were more patients alive that got Provenge than those who did not. And then Larry Fong, our colleague at the University of California in San Francisco, did a study where he looked to see what happens when you give patients Provenge. And you can see that in a prostate cancer that's untreated, there's very few T cells here, where in this pink staining, you can see that a patient who received Provenge has much more T cells. And these are the good T cells that help kill the cancer. All right, now I want to get to the concept of immune checkpoint therapy. But before I go there, are there any questions that anyone has? And please note that I don't have the ability when I'm sharing this PowerPoint to see the screen. So I'm going to ask our hosts, Aaron and John, if there's any questions to let me know.
Sure,
Hi,
Doctor. Oh, go
Are
ahead.
you able to hear me okay?
I'm here. I'm able to hear both of you, actually.
Oh, okay. We've got one question from Douglas. Will you also be able to discuss promise of CAR T cell therapy?
Yeah, that's a great question. So that's not part of my presentation because I think it's a much further away in solid tumors like prostate cancer. Where CAR T cells have been most successful is with lymphomas, again, a blood-based cancer, and it's actually already FDA approved in that setting. And so I believe University of Pennsylvania and the City of Hope are doing clinical trials with CAR T cells in prostate cancer. But again, it's early on, and I think it's going to be another few years before it becomes one of the hottest things. But I think, so what I'm trying to say is definitely a future, but I don't think on its own right now, it's in the right place. Any other questions?
Yes, we had one more from Jerome. It seems like the Provenge was no better than placebo about 5 years ago.
And so Jerome, can you please clarify that? What do you mean by no better?
Okay, we're waiting. Jerome, I'm going to unmute your microphone. Hold on one second.
I think he's referring to why the lines cross after 5 years, the low survival rate.
Yeah, so great. Let me go back to these things. So he's talking about like right here, the numbers are just too small, meaning that there's too few people that are alive at that point. So it becomes statistically meaningless. That's why when we design clinical trials, we focus on the 50% mark because that's where the numbers are, what I'd say real. And what I mean by that is, for example, if I flip a coin 10 times and I get 10 heads in a row, we all know that flipping a coin, if you do it 1,000 times, you'll end up with pretty much 50% of time, or 500 times will be heads and about 500 times will be tails. So you just need larger numbers to make that assessment. So when we're looking at numbers at the 5-year mark, there's just too few patients to actually make any statistical comment. I hope that clarifies your question, Jerome.
We do have another question from Ernest. University of Pennsylvania has been studying T cells with CRISPR that deletes 3 genes interfering with effectiveness and inserts a synthetic gene that gives the T cells a claw-like protein receptor for finding a molecule on specific cancer cells. Their 2019 trial found the process to be safe. Do you see PCA applications soon?
Yes, I do think that that will be one strategy, but what you will see by the data that I'll show you is just getting T cells into the prostate cancer is insufficient. And there are many reasons for that that I'll try to get the point across. So I do think that CRISPR technology has a role in cancer. Again, I believe it's too early to be promoting that with my patients. But again, a few years from now, it will be one strategy, but I don't think on its own it's going to be successful.
All right. A couple more questions here. Are there any other indicators besides PSA readings to determine the advance or reduction of cancer advance?
So with my patients, I use 3 indicators. One, themselves, meaning if they're having symptoms, like for example, in my clinic yesterday, one of my patients said he was having more blood in his urine and he was passing clots. That's a symptom. Another patient was complaining about having worsening bone pain. That's so that's a third one. And a third patient had 2 urinary tract infections in a short amount of time. Those to me were patient symptoms that indicated, before I even saw the PSA, before I even saw the scans, that the patient is potentially progressing. So I always choose, number 1 is my patients. Number 2 is the PSA. Obviously, if it's going up, that's always concerning, but I have to be mindful that sometimes PSAs go up and the treatment's still working. So I don't want people to be overly obsessed with it. And third is the scans themselves. They will help us understand whether cancer is spreading or not. I want to share with you one anecdote early on in my career that I'll never forget. The patient's PSA was 0 while I was treating him for his prostate cancer. And he developed right hip pain. And I'd done a CAT scan and a bone scan, and it had said that the cancer is not spreading. It's been stable for the last couple of years with the patient's PSA 0. And then I've looked into patient's history and I go, you had a right hip repair 10 years ago. So I want you to go to your surgeon who repaired it and ask him to take a look. The patient comes back a month later and says, you know what? The surgeon says it's actually your fault. And now the patient was actually in a wheelchair because he couldn't walk anymore. Well, I did an MRI and it showed that it was actually the cancer. And so early in my career, I was obsessed with PSA. And remember, this patient's PSA was 0, and yet his cancer had progressed. So I've learned to always, always, always listen to the patient first and then figure things out. I hope that answers the question.
And I think we have just one more question before you can continue. Can you highlight in your presentation which immunotherapies might be readily accessible to people that are currently stage 4?
So that's a simple question. I already did. That's Provenge. Everything else is in clinical trials.
Great. I think that's it for the questions. So please go ahead.
All right. So what I want to show you is the work of my mentor, Jim Allison, who's also won the Nobel Prize a couple of years ago. And so he just a scientist that just really wanted to understand how T cells work, because we understand that T cells are the one that actually can kill the cancer of all the immune cells. And so here's a T cell in the middle right here, and it recognizes cancer through this protein called a T cell receptor, or TCR for short. And when that protein recognizes the cancer, it signals a T cell, but nothing happens. And the analogy I like to use, it's like putting the car key in the ignition, and you turn the ignition so you can hear the car running, but the car's not moving at all. So that's what this is. When these two things engage each other, it signals, but it doesn't cause the T cells to do anything major. In order to get the T cells to actually start becoming active, it needs a second signal, which is another protein called CD28 that interacts with another set of cells, such as dendritic cells and macrophages, to get stimulated. Now, if we think about the analogy of the car, that's like putting the key in ignition and then putting your foot on the accelerator, right? So now the car is moving forward. Now, the problem is, if you can think about it, a car that's moving forward, eventually you're going to want to hit the brakes. Otherwise, you're going to crash, right? Bad things will happen. So the cars have a brake. So Dr. Allison, or Jim Allison, figured out that when you have an immune system that's actively going wild, let's say you have an infection. Many of us who have kids or who gets colds, what do? We feel around our neck because there's lymph nodes around here. Lymph nodes are where the immune system, especially T cells, goes to fight the infection, and they get swollen when it's infected. Well, think about it. If there were no brakes on the immune system, those lymph nodes would get bigger and bigger to the point where we couldn't breathe, or they just explode. So what Jim Allison did, him and a separate laboratory, Jeffrey Bluestone, they both figured out that CTLA-4 is the brake on the T cells, okay? And it turns out mice that genetically lack CTLA-4 die from a lymphoproliferative disease within 2 to 3 weeks of age. Lymphoproliferative disease means the lymph node just gets so big that they just explode. And what Jim Allison next did, he developed a drug that blocks the brakes, because he knows that cancer cells put brakes on the immune cells. And so he blocked the brakes, and he did it to mice that had cancer, and it cured a subset of mice. So that's how this immune checkpoint therapy worked. Well, since then, 2 other brakes were discovered, PD-1 and PD-L1. So now 3 brakes. Well, the first brake, CTLA-4, which is now known as ipilimumab or Yervoy, was tested in melanoma. And what you're seeing here, this one arm, so they had 3 different arms in the study, meaning patients were either given Yervoy alone, Yervoy plus a vaccine, or the vaccine alone. And what you can see, anyone that got Yervoy, otherwise known as ipilimumab, they're the ones at 50% time did better. But what's amazing, for the first time, we're seeing a tail at the end of the curve. What we mean by tail is you can see it's not going towards 0. It's just staying straight. And in fact, when they looked at approximately 5,000 patients, you can see that tail starts developing around year 3 or 4, and it maintains itself for 10 years, okay? But going back to what I said earlier about numbers, you can see we start off with 5,000 people, but as we get closer to 10 years, there's only five people here. So it becomes statistically less meaningless. But we can say that definitely at 6 years, there's 120 people that are still being affected. So this brought on a field known as immune checkpoint therapies. And what's the good thing about it is a subset of patients benefit. But there are some toxicities known with it, and they have a special name. that's called immune-related adverse events. And then measuring the cancer can actually be difficult. And I'll show you examples of all three. So here is, we're talking about toxicities. These toxicities can affect any part of the body. It can affect your brain, it can affect your heart, lungs, colon, skin. And so it's something that you just have to be worried about. Skin is the most common, and it comes in the form of rash. And the second most common is the colon, where you can get diarrhea. And then a less common one, because it happens in about 3 to 10% of people, it can affect the lungs, where it causes people to have cough or shortness of breath. And then another one is where it can attack a part of the brain that causes fatigue, severe fatigue. So when people hear about diarrhea, I want to show you an example of a patient of mine that called me 4 in the morning 5 years ago. This is the text message I got on my phone, and the wife was in a panic on what to do. Don't worry, the patient is doing great. I saw him in clinic a couple of months ago, but my point is, it can be scary if it's not handled properly and well. Now, in regards to the challenges of measuring the cancer, this is a patient with melanoma. You can see melanoma is a deadly skin cancer, and this patient had exhausted all sorts of therapies. There was nothing else. He was given a chance to go on the trial with ipilimumab versus hospice, or what we call palliative care. And you can see that his cancer is pretty big. He got 1 dose of ipilimumab, and you can see the cancer actually grew. On the right-hand side is the CAT scan for those who with medical backgrounds, but I think just looking at the skin is sufficient. And then you can see, after the patient went to hospice because he was told to get off the study, the cancer started shrinking, and it finally disappeared. So he was cured from 1 dose of this drug. That's not common to be cured by 1 dose, by the way. So when we think of how drugs are developed right now, we used to think of, and we're just looking at survival, we have the drug that's already well known versus a new drug, and we're just trying to see at 50% of patients, are they living longer? But at the end of the day, none of the drugs cure. And so eventually the patients will succumb to their cancer. But with this new form of immunotherapy, you can see that there's a tail at the end of the curve. In melanoma, that tail's around 20%. And one of our goals is, how do we get it so it's 80 to 100%? So a majority of our patients are benefiting. And I just bring back the melanoma picture where I'm saying it's about 20%, as you can see. Trying to skip through this. Okay, so what they did in melanoma is they combined 2 of the checkpoints, PD-1 and CTLA-4, and you can see they got the curve to be around 58% in the yellow right here. Okay, so combinations can actually be more effective, and because of this, Science magazine called immune checkpoint therapies the breakthrough of the year. And as a result of the 3 immune checkpoints, CTLA-4, PD-1, PD-L1, pharmaceutical companies have now FDA approval of all these drugs in the various cancers that are shown in blue. The problem is, as you can see, prostate cancer is not one of them. So let's talk about that. And again, this is Jim Allison and Tasuku Honjo, who were awarded the Nobel Prize in 2018. So here's the question. Do immune checkpoint therapies work in prostate cancer patients? And so this is what we call the landscape of prostate cancer, where you have Sipuleucel T, the hormonal therapies, the chemotherapies, and another chemotherapy, docetaxel and cabazitaxel shown here, and then Xofigo or radium-223. So if you look historically, in 2004, there was only 1 drug that improved survival for prostate cancer, and that was docetaxel, otherwise known as Taxotere chemotherapy. So what they did with ipilimumab, they tested it in the pre-chemotherapy setting and the post-chemotherapy setting to see where it would work better. And they also tested anti-PD-1. And when they tested anti-PD-1, none of the patients had any responses. So that killed the development of anti-PD-1. So with ipilimumab, they looked in the pre-chemotherapy setting, and they actually compared it to placebo. And what you see is the curves virtually overlap. So there's really no benefit with that. And then they also did it in the post-chemotherapy setting. But in the post-chemotherapy setting, they compared placebo plus radiation therapy versus radiation therapy plus ipilimumab. And here what's interesting is the ipilimumab's in blue, and you can see that compared to placebo early on, it actually seems to harm more patients, but then it crosses over and it seems to benefit. But this wasn't considered a statistically significant benefit. And so, because the p-value was only 0.053. But I want to point out, there was a tail at the end of the curve. It was around 15% here. That a little lower than what you see in melanoma, but it suggested that a subset of patients actually benefited. Like I pointed out before, there were people that were harmed. And I think that these are the patients that had early toxicities from the immunotherapy. So the question is, we asked at MD Anderson, can we identify those patients who may have benefited from ipilimumab? And so we did a quick trial with 30 patients, and each of the patients were asked to either give us a biopsy or remove some of their prostate cancer. And then they got 4 doses of the immunotherapy, and then we followed them. And this is an interesting way to plot it. So this is looking at overall survival in months in the x-axis. On the y-axis is progression-free survival. So it's meaning when on the CAT scan or bone scan did the cancer progress. And what we did when we did this, we found there's 3 groups of patients. The ones in green who had a long progression-free survival and long overall survival, and the other extreme in purple, a short progression-free survival and a short, less than 1 year overall survival. And so we consider green the favorable group and the purple the unfavorable group. And what you can see is the favorable group actually has more T cells staining in brown than the unfavorable group. So if you have more T cells in there, you're more likely to benefit from this immunotherapy. I want to now pause and switch screens to a video that I want to show you guys on a patient of ours that received treatment on this. So let me go to here.
I like to solve problems. I just like to go at them, and if I make 10 mistakes, that's fine. I'll get those 10 mistakes out of the way, and I'll finally figure out what was the right thing to do. I'm a professor at UC Berkeley in mechanical engineering. I've always liked exercising. I walk everywhere. I never in the car. I started log rolling when I was 10 or 11, like to play a little baseball with my son. I was diagnosed with cancer in November of 2014 after a long 1.5 year period of discomfort. And at one point I made like just a little graph, and it was just going down so quickly. I remember thinking, like, at this rate, I mean, I'm not going to be alive in 3 months. The biopsy showed very extensive and high-grade cancer in my prostate. It had spread to lymph nodes and some nerves, part of my bladder and my bones. Started the hormone therapy the next day, and then chemotherapy right away as well.
When we found out that this was Andy's diagnosis, we knew it was bad. The first thing I was researching like crazy, are there any trials? I think the state of the disease was such that there was just nothing here.
And then through friends, we were recommended to MD Anderson in Houston. And Johanna did a lot of the legwork, just making that happen. You know, I think if Johanna hadn't have been there to just help me through the logistics, among other things, it's too intimidating. I think the thought of traveling there, even that point, seemed daunting. But enough people encouraged us that we had to go once. I've come to really not mind traveling at all. It actually makes me feel like I'm taking things really seriously and doing everything I can. I had surgery there in June of 2015. Started my clinical trial less than a year after I had been diagnosed.
Andy received an immunotherapy known as ipilimumab or Yervoy. It's a drug that temporarily removes the brakes off the T cells, which are the immune cells that help fight cancer.
And so here was this option of something that was pretty exciting. Yes, it was also a little scary because there are all these side effects, but we were all in. We just wanted to go forward and make it happen.
I was supposed to receive 4 doses of ipilimumab every 3 weeks. I ended up only getting 3 treatments.
Andy actually developed one of the most typical side effects from this immunotherapy, which is when the immune cells actually attacked his skin and caused a rash. However, Andy actually had one of the best responses we've seen with prostate cancer.
Dr. Subudhi said, you know, your immune system is suitably excited and we're not going to have this 4th dose. But they argued that it was not unusual. They were really learning how to do the dosing.
Andy is defying the odds. For patients like Andy, median survival would have been measured in probably 2 to 4 years. And I believe that this trial has changed that prognosis significantly. 1 year after he started his treatment, he texted me a picture of him and he's like, look, I'm 1 year out. And I shared that with the rest of our team saying, this is why we do what we do.
Being included in the trial gave me a huge amount of hope. It's a year and a half later since the immunotherapy and I feel great. I'm active, although I've had a little bit of progression of my PSA. I'm grateful to have been on the trial, and I would do any other trial pretty much right away, given the opportunity.
Going through the immunotherapy and coming out and being without any kind of treatment for the last year has been for me a huge win. That's the other big piece of hope. There's breakthroughs all the time. It's amazing to me how quickly things change.
Immunotherapy is really going to be a new and long-lasting treatment for cancer. Given that the Cancer Research Institute's main objective is to promote the funding and understanding of immunotherapy, it seems like a wonderful thing and will ultimately change a lot of lives for the better.
All right. Now let me display settings, switch that. Okay. Okay, so then the question is, we know that when we try this drug with a larger group of patients, there is no difference in the overall population, but there's definitely a subset of people who benefit. The question is, can we improve on who benefits? And so we looked at what happens when you give this drug, and we looked inside the cancer cells, and you can see in prostate cancer, there's 2 types of T cells, CD4 T cells and CD8 T cells. And there's very few T cells, you can see them in brown, very few before you give the treatment. But after you give the treatment, you can see you bring in a lot of T cells. And this is what I was trying to show earlier, that other therapies, whether it's CAR T cells or the CRISPR therapy that was brought up by the audience members, they can drive in T cells, just like vaccines. But sometimes that's just not enough. And to better understand why it's not enough, what we ended up doing is we ended up looking at a lot of different genes, and we found that the PD-1, PD-L1 brakes were upregulated within the cancer. So the cancer was smart. It saw these T cells coming in, it knew it was going to die, so it put up other brakes up in order to prevent those T cells from killing it. And so what we did next is we actually use fancy microscopes to color the T cells, the tumor cells, and other immune cells such as macrophages and CD68. And we found that a lot of the brakes were upregulated on the T cells themselves, the the macrophages, you know what, I need to get my laser pointer back up. So you can see it, there we go. So you can see that it's upregulated on the T cells itself, the macrophages in yellow, and the tumor cells themselves. So the cancer is smart. And so the other thing is we looked at, well, why does this drug work in melanoma patients, but not in prostate cancer? And it turns out that in melanoma, they don't have as many of these macrophages that are bad that prostate cancer has. So prostate cancer has a lot more of this than melanoma does. And it's also got a different set of macrophages, again, lower in melanoma than compared to prostate cancer. So these are the breaks that the cancer is putting up. And it turns out when you treat mice that have prostate cancer and you target both CTLA-4 and the other breaks, in green, you can see these mice actually live longer with the combination. So that led us to say, hey, why don't we do this in our prostate cancer patients? And so that's exactly what we did. We chose patients with pre-chemotherapy and those with post-chemotherapy and gave them the combination of treatments. And we did actually see some benefit, 25% in the pre-chemotherapy and about 10% in the post-chemotherapy. That never been seen before. I know it's still low, but it's still one of the highest that we've ever seen in prostate cancer. And this is an example of a patient I personally treated. His PSA within 12 months of starting had gone from 50 to almost 500. And after getting one dose of the drug, it went down to 300. And after 2 doses of the combination, you can see it went down to 0. He's now literally 4 years out of treatment and his PSA is still 0. You can see his lymph node has disappeared, and also his bone lesions that were in the beginning have disappeared as well. So we believe he's actually cured. And these are the 11 patients that were treated on this study that actually had long-term effects. And like I said 4 years. That's because this data or this slide is about 3 years old, and that's why you're not seeing this patient here who should have been like the arrow should keep going. But anyway, point is, many of these patients have ongoing effects, which is pretty incredible. So the conclusion is combining both drugs can actually improve things in prostate cancer. What I didn't tell you was that both drugs were actually highly toxic together. And it's because of the dosing and schedule we use was the melanoma dosing. It turns out that the dosing and schedule is a lot less toxic if you use the kidney version or the lung version. And so that's one of the approaches that we're thinking about. But as I pointed out earlier, this is not the home run because we're not seeing 80% to 100% people living longer. So we need other combinations. So one of the things that we thought about in our group is, well, what's going on in the bone tumor microenvironment? And the reason why we thought about the bone is because you can see is most patients, so this is looking at 10,000 patients, only 6% of people have it only in the lymph nodes. A majority have it in the bones only at 43%, but another subset have bone plus lymph node. So the amount that approximately 70% of patients have it in the bones. And when you have it in the bones, you survive less than when you have it in the lymph nodes only. Because there's something going on in the bones themselves. So we looked, and here's the bones, and we're looking at T cells. And the thing is, we see very little T cells in the cancer itself, where it's probably hard for you guys to see, but there's a lot of brown cells outside of the cancer. Those are the T cells. So this is a graph showing it. In the normal bone, there's a lot of T cells. Inside the cancer cell, there's few. And then if you look at, and this is inside the bone metastatic site, but if you look in the prostate cancer, the primary site, there's more than what you would see in a bone, but less than in a normal bone. So the bone is a site that is immunosuppressive. We then also looked at a lot of different cytokines and found that this cytokine, TGF-beta, was high in the mouse. And so in this particular mouse with prostate cancer, we're able to look at a bone that's free of cancer and another bone that has cancer. So we can compare in the same mouse the different cytokine levels. And you can see the one with the cancer has more of this TGF-beta. Why do I care? Because it turns out that when you target both CTLA-4 and TGF-beta, you get more T cells there and you increase survival in these mice. So we are now developing a trial to target CTLA-4 and TGF-beta in patients who have predominantly bone diseases. So we believe that targeting this TGF-beta and the PD-1 pathways are a path forward. So when we think about rational combination for prostate cancer, we want to increase the amount of T cells that are going in. We want to target the brakes, the immune checkpoints. We also want to get rid of the bad cells like the immunosuppressive macrophages. And there's other factors that I haven't had a chance to talk about, like metabolism, microbiome, et cetera. And then we also have to think about how we can improve patient selection. I want to point out, I only talked about 3 immune checkpoints. You can see here, and this is about 5 years old or 10 years old. There's significantly more immune checkpoints that have been discovered since then. And our goal ultimately is to get to this red here, where 80 to 100% of patients are getting cured. And first and foremost, I would like to acknowledge my patients who had the courage to go on these experimental trials and provide us the gift of their, not only their lives, but also their blood and tissues so that we can better understand how these drugs work. My colleagues at MD Anderson, the clinical trial group that helped us run this trial, and then also some of our supporting laboratories and funding sources. And now I'd like to just open it up to questions to the group.
Doctor, that was a fantastic presentation. Certainly plenty of it was over my head. I'm pretty new to the immunotherapy side of things, but it's really exciting when we see something that has so much promise, and hope to see it, as a widespread treatment as soon as possible. I got to apologize. There was one question from way back that I had overlooked. As a patient, how do you know that the Provenge treatment is working?
Yeah, that's a great question. And I spend about 20 to 30 extra minutes every time I talk about Provenge trying to answer that question. The truth is you don't. So all the study shows is that the people who got it were more likely to live longer than people who did not. But I think whoever was asking the question has a little bit more insight than the general audience, in the sense that we know that Provenge doesn't change the PSA levels. They usually will continue to go up. And in fact, the scans will continue to show that the cancer is progressing. And so how can a drug make people live longer, yet the PSA goes up and the scans show that the cancer is progressing? And the only way that can happen is it's got to be slowing the rate at which the cancer is growing. And I hope that answers your question.
Gotcha. We have another question here, two-part question. Do you control at all for gut microbiome in your human studies?
Yeah, that's an awesome question. It's something that we're thinking about doing, and how to do it is not easy. One of the things that I've been doing because of the work done by our melanoma colleagues at MD Anderson, they found that patients who are on probiotics, which can affect the gut microbiome, don't seem to respond as well to the immune checkpoint therapies. In addition, anyone who's got antibiotics within 2 months of starting immune checkpoint therapies don't respond as well, because antibiotics can also affect the gut microbiome. So we are engaging in studies to look at that. I would tell you that the University of Oregon actually has a study where they're taking fecal samples from someone who had responded well to immune checkpoint therapy, transplanting that fecal sample into the patient, a prostate patient who's going to receive the immune checkpoint therapy to see if that works. But it's a great question because it's something that we're all actively thinking about how to do it best.
Interesting. The other part of that question from Douglas was some doctors are using cryoablation and intratumoral injection of checkpoint inhibitors. What do you think of this approach?
Yeah, in theory, it sounds great. I have actually had a patient that had that done and didn't work at all, and he's not doing well. And the problem is that it wasn't well studied in whoever designed the trial. And the problem for my patient now is he's excluded from a lot of trials because now he's gotten these treatments. He can't go on other trials that are having the same combinations. So what I'm trying to say is that, yes, in theory, it sounds great, but it's not turning out to be as well as we think.
Gotcha. A question from Gary is, would you use Provenge or any immunotherapy in a patient who has cancer only in the prostate?
Yeah, so only as an experiment, but not as a standard of care. And the reason for that is because it doesn't seem like, and because actually Larry Fong at the University of California in San Francisco did this study, and it didn't seem to cure the high-risk patients. Now, I do want to tell you there's an ongoing trial in patients with active surveillance. So these are patients with low-risk prostate cancer. And remember, these are the ones that I alluded to earlier, most likely don't need radiation or need surgery for cure, to see if giving the Provenge in that setting will actually lead to more cures.
Gotcha. Joel has asked if you could show the slide showing the lymph bone and bone and lymph survival in months again.
Yeah, I can do that.
And doctor, you able to hear me?
Yes.
Would it be possible for us to be able to have a copy of these slides that we could put in our presentation?
Absolutely. Yes, I could do that.
Thank you.
Do this. Give me a sec. All right. Display settings. And oh, somehow went there. Let me do this. Let me try some other way. You can see that screen, right? Can you guys see these screens?
Yes, we can.
Yes.
All right, so let me just go backwards this way. There we go. I think this is the slide that you're talking about. Is that correct? And this was a study done by Susan Halaby at Duke University. She's a biostatistician, and she looked at 10,000 patients who were treated on phase 3 studies with docetaxel chemotherapy-based treatments. And this is what the numbers. Is there a question to this, or someone just wanted to see it?
He asked just to see it again,
Okay.
but maybe you can just keep that up for the moment in case he types in a question. We did have another question that just came in. Hang on, I seem to have lost that question. Here it is. In what order does docetaxel, Provenge, and immunotherapy be given? If chemo given after Provenge destroys Provenge benefit?
Yeah, I'm not sure if chemo after, so I don't necessarily agree with chemo after Provenge destroys Provenge benefit. The reason for that is that, yes, chemotherapy does wipe out some of the immune system, but not the memory T cells that we want. So I wouldn't agree with that statement. In regards to the order of things, I personally like to give Provenge up front because even though, as I mentioned earlier, that in a majority of patients, the PSAs will go up and the scans will show that things get worse. I have, I'd say about 5% of patients where, and I actually had 2 in clinic yesterday, where they have not needed anything for 2 to 3 years since Provenge because it's keeping the cancer in check. So, you know, I have to tell you, those are patients who got Provenge when their PSAs were lower. And the studies, there are studies that back it up, that the lower your PSA, the more benefit the Provenge can have.
Interesting. All right. I think that's all the questions that I've seen. Oh, hang on. I think there was one I might have missed. I think I missed this question from Doug. There is emerging evidence that CD8 T cell numbers or potency tends to decrease markedly in old men relative to other groups. Does or will this affect immunotherapy options?
Yeah, no, he's absolutely right. And that could also account for why immunotherapies have not been as successful in prostate cancer as in other cancers. But the truth is, some of my patients that have had wonderful effects with immunotherapy have been in their 70s. And so, and late 70s for that matter. So it's not a one size fits all. I believe that there are drugs, and including technologies that we already talked about by the audience, CAR T cells and CRISPR, that can boost even a substandard or subpar immune system to boost it up. So as long as a patient has an immune system, I believe we can develop the right drugs to get them boosted enough to fight the cancer.
Great. All right, I think that's it for the questions. Does anyone else online have any other questions? Just give you another minute to type anything in. And
we do
I
have
also noticed,
one question in the Q&A.
oh, okay. I see it. Please show next to last slide showing checkpoint therapy.
Like these?
Oh, wow. Sheldon, is hopefully that's the slide you wanted to see?
Because the last, or does he want this one? Because the last slide is this.
He did say showing checkpoint therapy.
So these are the novel checkpoints that are out there, and this is an old slide.
All right, hopefully that's, wow, must have a ton of research going on.
There is a lot of clinical trials for that matter.
Yeah. Okay, I think this is a question for clarification. Okay, Provenge first, followed by chemo or immunotherapy?
Yes, okay, so I personally, in my own practice, I don't do a one size fits all. And I brought it up again with someone in my clinic yesterday that I met for the first time, asked me a similar question. And here's the reason why. It all depends on the person in front of you. If a patient is symptomatic, like he's coming in and his cancer is on fire, meaning you can see he's limping or he's got tingling in his legs, I'm going to go to chemotherapy right away. I'm not going to wait. Same patient, meaning the patient has a twin brother whose cancer seems to be okay. Like if I met the patient in Home Depot or Costco, I would never even know he had cancer. That to me is a person that I would do Provenge first. Now, in regards to immunotherapy, remember, those are trials. So there are trials that open and close all the time. I have 2 more spots left in one of my trials. And so, and it's one of those things that's unfortunate because it's first come, first serve. And so, you know, I anticipate by next week, by next Wednesday, that trial will be shut down. And so you just, since immunotherapy is being used in clinical trials, except for Provenge, which has been FDA approved since 2010, you just have to see when the trials are available. Because some trials actually combine drugs with Provenge, right? So, so there's not an easy question to answer the immunotherapy part.
Gotcha. John, I think you had a question.
Yes, doctor. What, for someone that has had surgery, radiation, and gone through doxycycline, what is available immune therapy wise for someone that after 10 or 15 years, it starts creeping back again?
Yeah, so it sounds like if it's creeping up, we call that the rising PSA, the biochemical recurrence, where the PSA is going up, but you've already had 2 chances to try to cure with surgery and or radiation. And so now you have incurable cancer. And the question is, what can we do next? There are a few trials out there. In fact, Columbia University with Chuck Drake and Matthew Dallas are running the Magic 8 trial that has immunotherapy in that setting. So that's something to be considered. But again, that's experimental. But the standard of care right now for the setting that I believe the question, or the person that asked you the question, John, is I believe there's just their PSA is going up. And when you do a scan, you don't see any signs of cancer. And in that setting, it's either just to watch the PSA, and I know it's people are like, well, why would you watch it? Why won't you do something about it? And part of my thinking is that if I can't cure you, why am I going to give you a side effect just because a PSA is going up? The PSA is not causing you any symptoms or anything like that. And we can't forget that the hormonal therapies increase your chances of cardiovascular disease, such as heart attacks and strokes, causes weight gain, causes osteoporosis. So one option is just to watch it and then pick a number or time when you will start it. The other is clinical trials.
All right. Well, we haven't had any additional questions come up. Doctor, I'd like to thank you for a fantastic presentation. We certainly do appreciate it. We had quite a few people online, and they stayed online. You definitely had a captive audience today.
Aaron, I appreciate that, and I promise to share my slides. But in this new COVID era, I have a feeling we'll be doing more types of presentations like this, and I would love some feedback from the audience, both constructive feedback on how we can improve things in the future.
Sounds good. Is your email address by chance? I can't remember whether I had it in my slides or not, but is it pretty easy to get your email address?
Yeah, and it's SK and then my last name Subudhi at mdanderson.org. Yes, and then if you wouldn't mind letting people know that when they contact me, the subject, 2 things. Number one, the subject line is very important because I get about 200 to 500 emails a day. And then the second thing is at MD Anderson, they have a very rigid spam selection. So I'm pretty good at responding back within 3 days. And if I don't, please don't think that I'm ignoring you, because that's not it. There's probably another reason.
All right. Anyone else have anything else that they would like to ask or address?
We did have one more Q&A. What PSA levels warrants ADT restart?
So I actually personally use, and it comes from the study done at Johns Hopkins University. I personally look at the PSA doubling time, and there's a calculator. If you just type into Google PSA doubling time calculator, there'll be one that comes up, and you can put in the dates and the days, the date of your PSA and the actual value of the PSA, and it'll calculate for you. But when the PSA doubling time is somewhere around 3 to 6 months, that's when I usually start ADT.
And I concur with Aaron. Great presentation, very informative, and I've learned quite a bit. And I've been involved with our group since 2009. Fantastic presentation. Thank you, Doctor.
Thank you for.
Thank you. Thanks a lot.